Hello, good afternoon, or good morning, or good evening, wherever you are. So my name is Marit Kalesvaart, and I'm here from Zurich in Switzerland, and I will be your moderator today. So I would like to welcome everyone to this first of two ILTS webinars on machine perfusion. And as you can see on the slides here is that these webinars are an initiative of the DCD and machine perfusion special interest groups. And together with Amelia Hesheimer, who is also here, from Barcelona, we are the topic coordinators of this special interest group. So during today's webinar, we discussed the basics of machine perfusion. So it's about understanding this new innovative technique. During next week's webinar, which is also planned on Friday on the same time, we will discuss the clinical application and also trials of machine perfusion. So before we start today, we in the ILTS, we would like to thank Bridge to Life for their support to make this webinar series possible. So we have three speakers today, and after every presentation, there will be time for questions. And at the end of the webinar, we will also have a discussion with the three speakers. So if you have a question, on the right side in your screen, you can see there's like a questions section. You can write your question there, but please also state your name and where you're from, and I will read the question at the end of the presentation. So now we go to our first speaker, who is James Guarrera, and he's a professor of surgery, of liver surgery and liver transplantation at the Rutgers, New Jersey Medical School in the United States. And Dr. Guarrera is an acknowledged international expert and also pioneer of ex vivo machine perfusion. And he is known for the first to actually use to have preserved human livers ex vivally, and he will now discuss or present to us an overview of the mechanisms of action and the effects of hypothermic machine perfusion. I would like to give the word to Dr. Guarrera.
Thanks, Marit, and thanks, Marit, Amelia, Karina, and the rest of the ILTS special interest group and leadership for the invitation to present. Let's get started. So these are my disclosures. As was described, I've been involved in this development and thus have had funding during the development phase from the U.S. government for the early work, and then now I'm working with Organ Recovery Systems for development of the LifePort liver transporter, which is currently in a pivotal trial, which I'll describe some of those early results. So we know that end-stage liver disease is a global problem. It's on the rise worldwide, despite the success of liver transplantation and the availability of liver transplantation. We still suffer from an organ gap. So the supply and demand just don't match up. The demand continues to exceed organ availability, which has led to an increased reliance on more marginal grafts, ECD, DCD grafts throughout the world. And issues with those marginal grafts are very sensitive to preservation. So with the more marginal grafts, organ preservation becomes a really pivotal characteristic and component of the transplant procedure. In addition, in some countries, there's increasing distances and issues with organ allocation to travel and procure grafts that are further away, which further complicate the matter and again beg for improvements in organ preservation technology. So ischemia reperfusion injury, as I said, is a major clinical issue. Hypoxia, inflammation, stress mediators, reactive oxygen species, structural changes that occur at reperfusion lead to hepatocellular injury, delayed allograft function, primary non-function in the most severe cases, and biliary complications that we talk about so much, particularly in the DCD subset of donors, like ischemic cholangiopathy, which are diffuse intrahepatic biliary strictures that are not amenable to intervention and require retransplant, or a very complicated issues ensue and frequently death without retransplant in the most severe cases. And this is a little bit of a busy slide, just showing some of the mechanisms, which I think most people are familiar with and can review. So, when we started looking at this, about 2 decades ago in the lab, this slide wasn't really controversial. And what's exciting for me now is that, 20 years later, this could be somewhat questionable, that the idea that the current standard for organ preservation is cold storage. And really, we're getting now to the point where that could be challenged by many, depending on where you are in the world and how much liver machine perfusion is being implemented, whether it be hypothermic or normothermic, or even those that are looking at other mid thermic temperatures. So the basis of hypothermia really is reduction of the metabolic demands of the graft in transit. And the issues that, like I mentioned, though, is that you really have a finite amount of time in preservation, and that may be somewhat based on the comfort level of the surgeons, how long they're willing to accept and tolerate in cold ischemic time. But most importantly, the characteristics of the donor organ will really determine what the tolerance to cold ischemia will be. So a liver graft that has 40% macrosteatosis, for instance, will not tolerate ischemic times of 10 to 12 hours very well. You really be playing with fire to use that organ as a transplant without machine perfusion, for instance. Whereas a perfect 20-year-old standard criteria liver without steatosis or issues, you can put in 12 hours and the grafts will function well. And there may be slightly increased risk of biliary complications, but it's really not an issue. Obviously, cold storage, it's static, right? That's the main issue. There's no ability to monitor the organ, support the organ, intervene on the organ, or even look at viability markers or health. So by machine perfusion mitigating the preservation injury, we've shown great promise now with growing clinical data worldwide and by multiple groups, and is now really being widely applied to liver transplant really over the last decade. So we're really now in our 11th year of doing this clinically, and it's been really exciting. And by the perfusion technique really decreases the metabolic demand by having the hypothermic temperature preserved. And obviously this is where we diverge from the normothermic perfusion, which Dr. Friend will discuss in the next talk. The perfusion is a continuous perfusion with dynamic flow, washout, and flush of all the waste products that the graft is producing, and those waste products and cold storage will just maintain and be in contact with the endothelium. So oxygenation, obviously important, providing oxygen even though the metabolic demand is reduced. It's important for the recharging of the mitochondria, and we'll show a slide that depicts that a little later. And the one thing about the hypothermic technique is it does provide a fail-safe. If there's a pump failure or any device failure, you do maintain that protection that you see that we have with hypothermia, which is different again from the normothermic. As Marat mentioned, this was the first report from our group when I was over at Columbia, just describing the first 20 cases in an exploratory non-randomized cohort study that was funded. And really, we showed that this was this was really a proof of concept study showing that this was a safe and feasible technique, and led to actually, we saw really excellent early graft function. We saw a reduction in some parameters, particularly peak transaminases, even biliary complications. Again, this was not a study powered to show those differences, but it was at least a good first step, even a length of stay reduction in the cases that received the machine perfused livers, and also better early renal function. And that has been borne out in subsequent work by multiple groups. So we applied this in a second trial to extended criteria brain dead donors, where we reported 30 and had a reduced incidence of biliary complications. And again, really excellent results. Now the group from Zurich really pioneered the technique throughout Europe, and also diverged a little bit from the way we were approaching this by adding a much higher concentration of oxygen actively, and also just by perfusing only the portal vein, which led to a more simple cannulation and technique compared to ours, where we were also cannulating the hepatic artery. Our technique was not an active oxygenation technique at the time, but the system was open, and we would actually measure PO2s, and we were getting PO2s that were about 80 to 100. So we felt like there was adequate oxygen in our setup, in our system, which was sort of an open system. So we felt like that these experiences, I think, can be certainly, you know, are additive to each other. And, you know, subsequently, we learned quite a bit from the European groups in Zurich and also in the Netherlands about the importance of oxygen in maintaining integrity and mitochondrial viability and health of the organ ex vivo. Now, Andrea is going to speak a lot, you know, later, and I don't want to take any of her thunder away, but she published from the Zurich group and combined with her group when she was in the UK, really the largest series looking at machine perfusion for DCD versus DBD, and really had outstanding results with real significant reduction in non-anastomotic strictures or biliary ischemic cholangiopathy, and also graft survival. So this is sort of the current status of most of the recent publications, just showing that hypothermic oxygenated machine perfusion really reduces complications, improves early graft function, and allows use of organs that we might otherwise be declining if we did not improve the situation in terms of preservation due to the marginality of those particular grafts. And these are the current devices that are available. You see there's and also at some different time points in being used by various groups, and you can see subtle differences maybe in some cannulation techniques and equipment. And then the flow rates are one thing worth commenting. The Bridge to Life device, the VitaSmart, is now, I believe, entering a clinical trial nearby us in the U.S. And our device is in a pivotal trial, as I mentioned earlier. Now, the improvements in graft function that we see with these marginal grafts really are the real main issue that we have, and the real motivation for continuing to move these techniques forward. And I mentioned some of these studies that have shown improvements in both graft survival and reductions in biliary complications. I did mention there is quite a bit of science around the proposed protective mechanisms, reduction in the pro-inflammatory cytokines and damage cascade, recharging ATP stores, and reduction in mitochondrial injuries. Our perfusates that we're using in our trial has free radical scavengers and other antioxidant and vasodilatory additives that reduce reactive oxygen species and the oxidative stress at the time of reperfusion. And we've published several papers on this. And as well, there's really emerging literature on the topic and on some of the mechanisms that are protective. And again, I'll let Andrea talk about that you know, a little bit more, because she's really pioneered that work. And this is a current, this is from clinicaltrials.gov, just showing that currently we have you know, 11 clinical trials, some of which are completed, but also this was one of my trials that was completed, and then but certainly a good amount of trials still recruiting throughout the world. This is the pilot trial with the organ recovery systems device, the LifePort liver transporter, which I was instrumental in the design and development with the engineers and with the company. And you can see this is a fully portable device that can actually be taken, and during the clinical trial has been taken aboard aircraft and also in SUVs, suburban type SUVs, ambulances. And this is you know, so this is definitely a portable device that can be taken. It can only be taken on fixed wing. We haven't tested it yet in helicopter due to the vibrational issues. But hopefully we'll be working on that stabilization soon, so it could be taken on rotary aircraft. We have 10 centers in the trial, and we've transplanted now 119 patients with approximately 60 in each group. So this is coming to conclusion with the total enrollment to be 140 patients. And we've seen in the groups, this was from preliminary data from 2 centers, we've seen reduction in complications, particularly biliary complications in these groups. So what about future directions? I think, you know, extending the perfusion time with hypothermic machine perfusion will really allow truly elective liver transplant, which will make all of us surgeons very happy that we don't have to start cases at you know, 11 p.m. or midnight. and we can get some rest and have improved logistics. I think that's a huge thing. And I know Peter will talk about that because normothermic preservation certainly has shown that this is very, very possible. And normothermic preservation, will certainly outperform hypothermic perfusion in this likely in this setting in terms of extension of time. Combinations of preservation techniques, I'm not going to get into that too much, but there are papers that have been published, particularly from Robert Port's group in Groningen about this, using combination of techniques, of both techniques with excellent results for DCD. Standardization of viability markers, that's Andrea's talk upcoming, and then solution designs and therapeutic additives. So extension of perfusion times, as I said, there's some work from Professor Port's group in porcine livers, and then there was a study out of Italy from De Carlis showing extension of cold ischemia time with perfusion up to 20 hours. So this is certainly a exciting topic. And then this was the study I mentioned showing excellent results with combination of hypothermic and normothermic liver perfusion. In addition, future directions, viability assessment. I mean, there's a lot really emerging on these viability markers. And as I said, we'll let Andrea discuss that since that's the topic of her conversation. We are also taking from some of the literature. This was a biliary injury score, also by Van Ringe from Groningen that was just published. And we've actually started to look at that. And in our cases, we've looked at about 4 cases in each group. We've seen reduction in the biliary injury scores when we apply hypothermic machine perfusion, which is to be expected. And finally, we're also looking at these biliary fluid analysis. So after reperfusion, we collect bile and we look at the glucose utilization, which is a surrogate marker of the health of the biliary epithelium. So there is much more excitement. Obviously, the viability testing in a hypothermic environment is not as robust as it is in the normothermic environment, but we are really excited about some of the findings, and we're looking forward to Andrea's talk on novel biomarkers. So in conclusion, the hypothermic machine perfusion now has really entered a renaissance period with promising results and interest, and is really, I'd like to say, challenging the concept that static cold storage is the standard of care. Optimal temperature and protocol perfusate are still in investigation. We have multiple clinical trials underway, and there's really great promise in lengthening safe ex vivo times with machine perfusion techniques and allow more transplants from marginal donors, especially the DCDs, the ECDs. And ultimately, what we want to have less complications and have our patients have improved outcomes and do better. So just in terms of acknowledgments, my team, I like to thank Jerry Paniatova. She's a surgical resident in my lab. She spent 2 years and really has been the point person for all the not only the pivotal trial and really running all of that, but also actually doing the perfusions. And she actually also helped put these slides together. So I have to acknowledge her in bold and in a larger font. And then the other members of the team, the clinical team, my surgeons, Flavio Paterno, Carrie Lunsford, Lloyd Brown, and also Nick Prosopoulos, our hepatologists, have been huge supporters. My previous team at Columbia was Jean Imon and Ben Samstein, Tom Cato, and some of the earlier collaborators. Really, this would not have gone much further or would have certainly taken much longer without their support and their willingness to transplant these livers and to push this forward. And thanks to all the PIs in our clinical trial and our collaborators in the Department of Pathology. So with that, I'd like to turn it over, and thank you again for the opportunity to present.
Yes, James, thank you very much for this very nice overview of hypothermic machine perfusion. I have a question for you. What do you think? What is the limit that you have now for hypothermic machine perfusion? The time that you can perfuse, and then endoschemically, or also like, or as or when you just leave out the cold ischemia completely?
Yeah, so that's a great question. I mean, I think, Andrea may be able to chime in on this, as she published a paper showing, they were using DCDs from 75 or 80-year-olds. I mean, that was much more aggressive. In the US, I think our aggressivity is certainly less than most of the countries in Europe. And And the reason for that is that the tolerance for complications we're really regulatorily constricted at some level. Whereas if we don't have 1 year graft survivals over 92%, we'll get flagged and we'll have some regulatory issues. So I think surgeons are a little bit constricted in terms of applying techniques due to fear of risk, fear of complications and risk. Whereas certainly we would love to do more cases. So really we have really learned a lot from the work out of Europe about how aggressive we can be with the DCDs. And right now I'm in a pivotal trial, but within the next few months I should be able to be just basically selecting donors and then applying perfusion to them. But in a pivotal randomized trial, it again is still not necessarily the time to really push the envelope. In my previous trial with our sort of predicate device, we did get quite aggressive, and we're using 50% macro and other very dodgy livers. And there was a picture of one on one of my slides. But I think that really is where the rubber meets the road to see what are the sort of limits of what you can do with the perfusion. And I don't know. I think that's really an area that's still under investigation and needs people that sort of have a lot of nerve to keep pushing the envelope. But I don't know if Andrea wants to make a comment on that.
Thank you, James. Fantastic talk. I think we did experimentally 24 hours and 3 days without transplantation. I know Robert Porter is now transplanting after 24 hours hypothermic perfusion and testing. And there is data currently from Italy and also from Zurich on 8 hours with transplantation. And regarding the steatosis, I think there's a new paper from Turin group with a couple of livers of 60% macrosteatosis with cold perfusion, which are obviously DBD livers, but also more than 70 years of age. So I think we need to explore that further. You're definitely right. And we need also more mechanistical data about the duration of cold storage before, because we are now 8-10 hours. That is fine. But if we go beyond that, we need more data in this. But otherwise, fully agree.
Thank you. We also have a question from the public. Kevin O'Connor is asking James, how can OPOs be most helpful in advancing this approach? So the hypothermic perfusion, because liver discard rates are too high now in the United States, and we need to do better.
Right. Yeah, thanks, Kevin. That's a great question. I mean, Kevin's been involved in the development. I think Kevin invited me to give a talk on this probably 15 years ago. So like anything, that things develop slowly in terms of adoption. I mean, we're at the point now where we have basically 20 patients more to enroll, and then the FDA will have the device for clearance at the end of the follow-up period. So, the hope is once it's FDA cleared, it'll be people can go out, transplant centers will be able to go out, and OPOs will be able to go out and set up programs where they can put livers on the pump. I mean, in the US, we've just had a major change in allocation. So I think a lot more of the perfusion services run through the OPO will be helpful, because it's not uncommon that you'll have a local surgeon recover a liver, and if someone drops out due to a biopsy or visualization, which happens frequently, then the OPO is there with a surgeon who's got no skin in the game for his center, and there's a liver, and they need to place that liver. So I think OPOs having a perfusion program and being able to take the liver that's cross-clamped and put it on the machine and then continue to allocate would be huge. I mean, admittedly, I think probably the normothermic device, and Peter can comment on this, maybe for OPOs, something, if there's a major delay and issues with allocation, it could be that may be the technique to go for it as a sort of stationary thing while you're trying to allocate. But I think OPOs, we even see this in our clinical trial. We have 10 centers, and some centers have their own people and they're perfusing and they have the pump at their center, and other centers have the OPO basically doing the perfusion. So it still needs to be standardized, and a lot of it really depends on the level of interest and excitement of the OPO to participate in it. And so there'll definitely be further conversations along those lines now that we're at the point where the product is almost approved.
Okay, thank you very much. We will now go to our next speaker, who is Peter Friend. Peter Friend is a known professor of transplantation and HPV in Oxford in the United Kingdom, and is also director of the Oxford Transplant Center. And he is mainly known for his experimental and clinical experience with normothermic machine perfusion, also including the international randomized trial, the trial. So, Peter, here you go.
Thank you very much, and thank you very much for the opportunity of delivering this talk to this this webinar. It's a great honor. My topic is normothermic perfusion in liver transplantation mechanisms and benefits. And first, my disclosure: I am a co-founder of OrganOx, which is a spin-out company from the university set up to develop normothermic perfusion. So clinical liver normothermic machine perfusion is happening. It's no longer just a research activity. There are commercial devices on the market, commercial devices entering the market. So what are the questions? What should we address? We need to ask why we need it. What does it do? What are its current benefits? How does it work? And what are its potential benefits? So what does it do? Well, normothermic perfusion recreates physiology. We deliver oxygen, we deliver physiological temperature, we provide nutrients. We allow normal metabolic activity to be maintained during preservation. The intended benefits are to minimize ischemia reperfusion. Because the organ is functioning, we can measure that function as a surrogate for viability. We can allow normal innate cellular recovery mechanisms to repair the damage, some of the damage to the organ, for example, hypoxic injury. And lastly, and I think very exciting, we can think about interventions, therapies, ways of repairing or improving the organ. So why do we need it? Well, James has just explained exactly the same thing, so I'll go over this quickly, but there is increasing demand, and with increasing demand comes a waiting list mortality. Waiting list mortalities between 10 and 30%. Really unacceptable if you think about how that would be greeted if it was any other branch of medical practice. We're seeing higher risk donors, DCDs, older, steatotic, more diabetics, more patients with cardiovascular disease. And we have logistic challenges, all relating really to the issue of time, limited time. We have difficulties in allocating the right organ to the right place, the right patient at the right time. We sometimes have difficulty in getting patients in from considerable distances. This is particularly true, for example, in geographically very large countries such as Canada and Australia. There are issues with operating room logistics. We can't easily accept more than one organ at a time. And there are issues which James referred to about sustainability, operating all night, every night, staff burnout. We would all love to be able to make this into a more civilized occupation. So let's look specifically at some of the numbers. This is what happens to patients in the United States. It's looking at the cohort of patients who are listed in the USA for transplantation in the year 2015, looking 3 years later. 59% of them were transplanted, 31% of them had died or been removed from the waiting list because they were too sick, and 10% were still waiting. And now comes the paradox, because in the year 2018, and that's typical, only 68% of donor livers were utilized. In other words, only 68% of multi-organ deceased donors resulted in a liver transplant. That resulted in 3,500, almost 3,600 livers not being transplanted in a single year. Why is this? And the reason is that the transplant surgeon has a dilemma every time he or she is offered a liver for a particular patient. They've got to decide whether the risk posed by this organ is in the interests of this particular patient, or whether this particular patient would be better off waiting for a better organ at some point in the future. This is all therefore about uncertainty. If that surgeon knew what the outcome was going to be at a much better level of certainty, then that would almost certainly increase the utilization of organs. So what we want are organs which are tested, treated, and timely. We want safer organs, organs that have been quality assured, optimized, predictable organs. We want some logistic benefits. We want to be able to retrieve from wherever we want. We want to be able to allocate to whomever we wish. We want a sustainable service. Ideally, we'd like to operate during the day. But above all, we've got to get better at utilization. We've got to do better than 68%. We've got to be able to accept high-risk organs and test them for viability. We've got to do something about the waiting list mortality. Well, what do we know so far? Well, we know that we can achieve less damage, fewer discards, and longer preservation. This is a very brief synopsis of the multi-center European trial, the results of which were published a couple of years ago. 7 European liver transplant centers, 220 transplanted livers. The primary endpoint was peak AST, which is an injury marker, which is a surrogate for graft survival. There was a 49% reduction in peak AST. There was also a 20% increase in organ utilization, despite a 54% increase in preservation time. So that seems, on the face of it, to tick quite a lot of the boxes that I just put up. Now, in relation specifically to DCD organs, the effect was greatest in this high-risk group of organs. So although there was a significant effect in both DBD and DCD, the DBD reduction was 40% and the DCD reduction was 73%. And there were 53 DCD donors in this trial, so it's not a trivial cohort. In terms of ischemic cholangiopathy, again, a really fundamental question as soon as one thinks about DCD liver transplantation. This trial that used MRCP to look for evidence of intrahepatic strictures. We saw a reduction from 26% to 11%. That does not achieve statistical significance, and the trial was never powered for it to do so. But it is a reduction, and I think that's a hypothesis which remains to be confirmed. And I would point out that MRCP is a particularly sensitive way of looking at this problem, that only one liver in each arm of this trial actually required a retransplant for cholangiopathy. The group at Cambridge have been doing a lot of work looking at predictors of viability, particularly bile duct or biliary viability, and they've demonstrated really rather strong evidence that it's biliary biochemistry rather than bile volume that matters. And the strongest predictor in their experience, and this was published quite recently, is glucose, followed by sodium and pH. These are concentrations in the bile. So how should we use normothermic perfusion, and when should we use it? There are really two formats for using it. One, which is what we used in the European trial, which is continuous normothermic machine perfusion. Take the device out to the donor, put the liver on the device at the donor hospital, keep it perfused all the way through until the point of implantation. That involves obviously sending a whole team out with the device and the skills to operate it. An alternative, and one which has become, I think it's fair to say, increasingly popular, is post-static cold storage normothermic machine perfusion, which is what we call back to base. So the organ is retrieved and transported as usual and then put onto the machine back at the transplant hospital. That clearly has logistic advantages. It does not require the device to be portable, does not require technical skills to go out with the device, and so that's a good reason. On the other hand, we don't know whether it's as good in the very extreme situation. Sorry, I both skipped a slide there. We've tested this in a smaller study, which we call a back to base study, which is a three center 31 liver study, in which the back to base approach was tested. Simplified logistics and not requiring transporting it to transplant the device, but simply to transplant the organ in an ice box. Total preservation time was 14 hours, of which 6 hours was cold and 8.5 hours almost was warm. The peak AST in these 31 cases was 457. 13% of patients developed early allograft dysfunction. That's a low number. 10% experienced post-reperfusion syndrome, and the 30-day graft survival was 94%. So the conclusions from this single-arm study were that it was a very feasible way of using it. Now, this study was set up with an identical protocol to the previous multi-center European trial, so that we could compare the groups, and we have compared the groups, and in terms of both clinical and biochemical outcomes, these results indistinguishable from those in the normothermic perfusion group of the European trial, in other words, the device to donor trial. Now, taking this to the other extreme, the group from Guangzhou in China, Professor He and colleagues, have devised this very, very ingenious approach to organ retrieval and transplantation, which they describe as ischemia-free liver transplantation. I think they've done more than that. I think they've achieved cooling-free as well as ischemia-free liver transplantation. And essentially, what they described was attaching the liver to the perfusion device in situ in the donor, from taking it from the donor into the machine and from the machine into the recipient and transplanting it so that it never actually experienced a loss of perfusion with normothermic oxygenated blood. And you can see this first case they reported, which showed really very good results in a very markedly steatotic liver. And the same group has published a much larger group very recently, demonstrating that this is not a single case phenomenon, that it seems to be something which they can repeat. And this series included a number of extended criteria donor livers and a number that were standard criteria donor livers. And you can see the elegance of the process here in the diagrams. So what about viability assessment? One of the advantages of having the liver perfusing in a normothermic environment is we should be able to measure what it's doing, and it should be giving us some useful information. What is it we're actually looking at? Well, lactate clearance is what everyone looks at. Transaminase levels in the perfusate do seem to have some predictive value in terms of outcome. And if we want to know more about synthetic function from the liver, we can measure, for example, coagulation factors such as factor V. We look at hemodynamic parameters, particularly arterial and portal flows, and we look at bile, we look at volume, and we look at biochemistry. Now, I've referred to the biochemistry a few moments ago, which seems to be more important than the volume. Lactate clearance is very reassuring. We all like that. Liver surgeons like to see lactate clearing. It's kind of natural. The fact is, it is reassuring, but it's not definitive on its own. A liver does not need to have a very large number of functional hepatocytes to clear lactate. So lactate clearance is only important if it's absent. If a liver does not clear lactate to the physiological levels down to about 2.5 millimoles per liter within 2 hours, that's the cause for concern. But there's clear evidence that the converse is not necessarily true. So I'm going to talk about now a very important clinical trial carried out by colleagues at the University of Birmingham, where they used normothermic machine perfusion to test organs that have been discarded and to take the plunge and transplant those organs which appeared to be functioning, the so-called Vital study published earlier this year. And as in the States, about 1/3 of deceased donor liver offers in the UK do not result in a transplant. They accepted 31 high-risk livers, which have been turned down by all 7 UK liver transplant units. They perfused them for 4 hours. They then assessed them based on perfusion parameters, particularly pH, lactate clearance, glucose, bile, vascular flows, and perfusion characteristics, appearances. And on that basis, 71% of the livers were transplanted after a median of 18 hours of preservation, and all those livers were functioning 3 months later. So clear evidence that normothermic machine perfusion improves organ utilization. Now, just by way of interest, this paper was published very recently. It was actually from a presentation at the American Surgical Association, when what the investigators did was to simply look at UNOS data over the period 2016 to 2019. That's more than 30,000 retrieved livers, and asked the question as to how many of those were transplanted. And what they demonstrated was that the livers which had undergone normothermic machine perfusion were much more likely to have been transplanted. That's improved utilization with similar outcomes. Now, there are lots of caveats around a presentation, around data like this, because of course, these were all in clinical trials, and there are all sorts of selection biases which come into play. But I think it's an interesting trend nonetheless, and one which we look to see more of in the future. So how does normothermic machine perfusion work? Well, we don't know is the answer, but there are a number of likely candidates. First is avoiding cooling is probably good for biological tissue. Putting biological tissue in the icebox is not actually very good for it. Avoiding hypoxia and ischemia, or minimizing it. Allowing the organ to recover its cellular energy, its ATP stores. And I think very importantly, optimizing the organ before it's exposed to an inflammatory milieu. In other words, we are reperfusing the organ in an environment which does not contain the effector mechanisms of inflammation, the white cells, the platelets, the complement, the NK cells, everything else, all things which generate ischemia reperfusion, which is a form of acute inflammation. So we have to ask the question as to what else we should be doing during normothermic machine perfusion. What are the therapeutic interventions that we should be thinking about? Well, we do know that even without therapeutic interventions, some good things happen. This is a publication from colleagues at King's College Hospital demonstrating that livers that have been stored by normothermic machine perfusion compared to static cold storage demonstrate inhibition of pro-inflammatory genes and expression of regeneration genes. So there does appear to be some gene expression basis to the advantage. There is evidence from a number of sources. Here, the group of Robert Porter and colleagues, this is a rat reperfusion model looking at gamma GT and LDH markers of epithelial injury, that normothermic machine perfusion, particularly in DCD livers, that's the blocks on the right side of the two graphs, is associated with much less injury. There is also evidence for other benefits which we need to be aware of. This is a publication from the group in Toronto demonstrating that the sequestration of platelets following at the time of liver transplantation is reduced in livers that have been preserved by normothermic machine perfusion. And platelet aggregation is associated with sinusoidal cell injury. So we see that the drop in platelets, which is typical following liver transplantation, is less, and the sequestration of platelets seen 3 hours post-operatively is also less. Now, we don't know the magnitude of that benefit, but it's certainly interesting to observe that exists. So what are the ways in which we can use normothermic perfusion as a platform to treat the donor liver? We can use it to deliver drugs. We can use it to treat steatosis, to prevent ischemia reperfusion. We can use it to deliver nanoparticles with drugs which can treat or can be targeted to the endothelium. We can deliver cells, mesenchymal stem cells, regulatory T cells, antigen-presenting cells, extracellular vesicles, genes, so gene silencing, IL-10, which is an anti-inflammatory approach, immunomodulation, so for example, CTLA-4 Ig. These are all strategies waiting to be done. They haven't actually been proven, certainly not in a clinical environment. Some of them have had some very interesting experimental data, but we are looking at a very individualized approach to organ preservation, very different from the good old icebox. And this is a very simple intervention. This comes from the group of Thomas Minor and colleagues in Essen. And what he demonstrated, and this is again in a rat model, which is that a normothermic perfused organ subjected to a brief period of hyperthermia, that's 42 degrees for 10 minutes, demonstrates an enhanced expression of heat shock protein. And heat shock protein is protective, and its expression is associated, as you can see in the bottom left graph, with increased reperfusion bile production. So these are all examples of interventions which we need to think about exploring. And this is work done by my colleagues in Oxford, Leanne Hodgson and Carla Cereza, looking in steatotic livers, severely steatotic livers, declined for transplantation. And these livers have been perfused for periods of up to 48 hours, treated with drugs designed to mobilize fat from the steatotic liver cells, and also with the perfusion circuit, including a lipid filter. And what this demonstrates quite clearly is actually within a few hours, within 6 hours or so, it is possible to remove substantial amounts of fat from a very steatotic liver. Now, how much that matters, of course, remains to be seen. But this will be the basis for our next randomized trial to assess the benefit of precisely this approach. Sorry, I skipped a slide. And this is evidence again from Toronto, looking at demonstrating that normothermic perfusion is a very good environment to deliver gene therapy. In this case, an oligonucleotide called miraversin, which has the potential effect of inhibiting HCV or reinfection. To some extent, it doesn't matter what the gene is. It demonstrates that it's a much more effective way at delivering that gene than during cold storage. And evidence here from the lung transplant group in Toronto, and there's no reason to believe that what's seen in the lung should be any different from the liver, demonstrating the benefit of delivering IL-10 gene therapy to a perfused organ, and demonstrating that lungs treated in this way have a lower inflammation score on day 7 and significantly improved lung function. So these are all very exciting strategies, all, as it were, waiting to be tested in a clinical environment. So to conclude, there is increasing clinical experience of liver normothermic machine perfusion. There is evidence of benefits, certainly in terms of logistics and viability assessment and organ utilization, which is emerging. The mechanisms of action are complex, multifaceted, and incompletely understood. And there are exciting opportunities to add novel therapies to what we currently do, which is improved preservation. Thank you very much for your attention.
Yes, thank you very much, Peter, for this great talk about normothermic machine perfusion. We have some questions from the public. The first one is from Ian Alwyn, who's a transplant surgeon from the Netherlands, and he's asking if you have any experience with normothermic machine perfusion of DCD livers that have been retrieved after normothermic regional perfusion in the donor, and if so, what were the outcomes of these cases?
The answer is that it has been done. Colleagues in Cambridge have done this on a few occasions. They are very strong supporters of normothermic regional perfusion for DCDs. On some occasions, they have not liked the characteristics of the liver, the normothermic regional perfused liver, and they felt that it would be appropriate to place the liver on the normothermic machine perfusion system ex situ. And they found this to be satisfactory. They've been able to go ahead and transplant livers successfully. I don't have the precise numbers at my fingertips, but it's certainly an experiment which has been done successfully.
Mm-hmm. Okay, thank you. Then the second question is from Marco Maria Pascal. Do you have any data about PNF and early arterial complications after your technique, normothermic machine perfusion?
Yes, PNFs have. Sorry, I'm getting some interference. Not sure where it's coming from. Yes, PNFs have occurred in very small numbers. We believe that it is possible to detect non-functioning livers on the device before transplanting them, and we believe, therefore, that is the reason why it's possible to transplant more livers to improve utilization. We have a number of investigators around the world have explored the limits, and I think it's fair to say that we are learning more about how to interpret the parameters, the metrics during normothermic machine perfusion to make a primary graft non-function in an exceedingly rare event. But it is certainly the case that we are learning precisely how to interpret these data still.
Okay, thank you. There was just some error on the signal. I have a last question for you as well. You discussed these both techniques of endoschemic normothermic machine perfusion and also the device to donor approach. Have you seen any difference in results? That there's like better results with if the cold ischemia is completely left out, if there's just a very short period?
Well, the study we did not show a difference. My sense is, and there's a sense of a number of colleagues who also experienced in this field, is that when we get to the really, really marginal organs, so that the ultra-steatotic livers, or the highly marginal DCDs, there will be advantages in minimizing exposure to cold. But that has not been tested. So I think it's important that we have the capability of doing both and that we continue to explore both.
Thank you. Well, thank you very much again. And we will now go to our third speaker, Andrea Schlegel. She's an HPV and transplant surgeon and currently working in Florence in Italy at the Careggi Hospital. Andrea has done a lot of research on machine perfusion for over more than 10 years, and she has focused on the underlying mechanisms of ischemia reperfusion injury and also the protective effects of the novel machine perfusion technologies. And one of her main interests is also the development of new markers to predict organ viability during machine perfusion, and that's what she will be talking about now as well.
Thank you, Marion, for the introduction. Thank you for the invitation. It's an honor to speak here, and welcome everyone to this webinar. We heard a lot about the two competing techniques, currently cold or warm perfusion, and now we would like to look into the viability. And here's my layout. I think we will discuss a little bit what is viability testing and what is actually a good test and a reliable test. And then we have heard a few parameters already by Peter Friend. We will look at normothermic perfusion and also hypothermic perfusion. How can we assess the liver and some future perspectives? What do we actually expect from machine perfusion? And if I look at this slide, I can say it's very, very much. So we want to improve the organ, survival, reduce complications, costs, and we want to predict reliably and ideally quick on real time while we perfuse, because we would not necessarily prolong the preservation time if not needed. What is viability? On the left side, you see the definition. It comes, of course, from biology, from 1600. You can find the earliest definitions, and it is the ability to work as intended or to succeed. And in medical terms, it's to live, grow, and develop. So basically, it's about function. And Peter Friend mentioned that already. Now, on the right side of the slide, you see that what are viability tests? And immediately, you can find that it's more complicated. It is a composition of skills and attitudes of cells or tissues, and it is very important is the proportion of cells or tissues which are able to maintain or recover the state of survival. And I've highlighted a few in red, like the integrity is important, enzyme activity, of course, energy is very important, and the synthetical function of cells and tissues and organs, of course. Now, we expect, of course, clear guidelines and thresholds, and we will, when we continue with the next slides, find out how difficult that is. You've heard hypothermic and normothermic perfusion. Here's just an overview of the various applications and sorts, how we do it, and there's no concurrent uniform approach. You can do it upfront or end ischemic. You can perfuse 4 hours, 10 hours, 12 hours, and there's no uniform concept, which is one problem and impacts on the viability markers, of course. And on top of it, we don't know when to measure, what to measure, how, and which parameters are most predictable. Looking at the literature, more than 30 years ago, people started to think about this. I'm sure Starsel looked into that too. And the first report I found was in 85, so more than 35 years ago. In the meantime, this is a table. Rebecca, my colleague in Florence, put it together, and you see there's multiple things we can measure. We can look, of course, macroscopically. We can do ultrasound, fibroscan, histology. These are more modules or tools where we cannot say anything about function, but it is an important part of the assessment. And then you have various modalities like hemodynamics, blood gas, biochemical analysis, fluoroscopy, spectroscopy, and other time-consuming assessments we could, in theory, use also to confirm our easy detectable markers. Peter Friend has already touched this, so this is just an overview of what we measured during normothermic perfusion. You can see we look at perfusion parameters, low pressure resistance, and then of course important is the hepatocyte function. The main number of cells is the hepatocyte, and there are two components, the excretory function and the metabolic synthetical function, where we already heard some facts about lactate, and I will come back to that in a few seconds. The other thing we heard about is the cholangiocytes, and also the parameters there are very interesting and important. Hemodynamics, there are some values which should be achieved during normothermic perfusion. This is probably the most consistent parameter comparing different papers and groups. And the problem is that you see it on the graph. This is from Chris Watson's paper. There's not really a difference between transplantable and non-transplantable livers, always. And it could improve as a prognostic marker if it's correlated with liver size, weight, and then also histology, because of course steatotic or very macrosteatotic livers have impaired flow and perfusion rates. Transaminases, Professor Friend said that this is an important parameter, and he showed that in his trial as well. And overall, the role is not so well defined. Of course, we know during perfusion, AST, ALT leak into the perfusate. We have a washout effect. It is, first of all, not measured by many colleagues. It has just started recently. And what is clear, of course, as you see it in the graph from Chris Watson, if it's very high, of course, it's a no-go when you say, look, maybe we should not transplant this liver. And a couple of colleagues keep it going with the ALT threshold of 6,000, which is fairly high. You see that here. This is the paper from the Clavian group with the prolonged preservation, and you see that there's a difference in livers which were deemed not viable because they're not transplanted, and those which were viable less than 5,000, less than 6,000. And again, it can improve if you normalize it to weight per perfusate volume. Carlos has also declined livers in the study he did with Professor Friend and the entire team. You see there was an ALT above 9,000 and the liver was declined. The other two discards in his normothermic cohort, which is the back-to-base trials or endoischemic after cold storage, was lactate. And here you see the value 4.1 and 4.2, which in his cohort meant it re-increased. Lactate is an important marker. Professor Friend has said that already. We like this. We are happy if lactate is low. You see what happens in the cell. If you have hypoxia, lactate is accumulated. In normal cellular function, it feeds the mitochondria through the pyruvate cycle and goes into the TCA and is metabolized. And you see on this figure is from a very nice paper from the Australian group, where you see non-lactate clearing grafts and lactate clearing grafts. And the red curve clearly shows also the three phases. You have an initial increase, and then it decreases. And if you have a certain injury of the liver, it may increase again. And that is exactly the problem. We don't know. The longer we perfuse, sometimes it increases, and certain thresholds are defined. Another example here, lactate in livers to maintain viability. And lactate is also a surrogate marker for other function. If lactate is cleared, the liver has usually other good viability criteria achieved as well, including pH, for example, glucose or bile production. Few examples, each of the case series had also organs which cleared lactate and had then developed a graft loss in the recipient or even a PNF, as you see here in the orange case in Chris Watson's paper. So it is good if it is high, you can exclude it, but if it is good, it doesn't mean necessarily that the organ will work. This is an experimental study, I like it a lot, from the Toronto group in pigs, and you see there are DCD livers with 120 minutes warm ischemia time, and you see no PNF and a PNF group. When you look at the lactate, you cannot really discriminate only by looking at this parameter. And here, this slide summarizes another problem is the threshold. Most colleagues have defined 2.5 as a threshold in the first 2.5 hours. This was initially presented by the group from Birmingham and is also used in the recent Vital trial. And you see 2 millimole per liter, you see 1.7 millimole per liter in the different case series. And according to Carlos' paper, this is a re-increase in lactate. If it is down and in the criteria below the cutoff and increases again, they suggest to stop the procedure, to not implant the liver if there's an increase. It's not so easy. Ideally, lactate is combined with other parameters as seen already, or some colleagues suggest to use rather the area under the curve or the slope instead of a single value, and to correct it for weight and perfusate amount. Here you see, I don't want to speak a lot about these two parameters, but just another touch what is measured, and we heard about it. pH has loads of confounders in the perfusate, so certainly not a single parameter to rely on. The glucose metabolism is very interesting because it's indirectly linked also to the mitochondrial function, and a lack of ATP causes glucogenolysis, and then you have initially a high perfusate glucose, and if you stimulate and the liver is viable, you see that this glucose decreases throughout perfusion, and you can perform a glucose challenge test to further support this, which is done by different colleagues. Bile flow, I think this graph on the right side is most impressive, and Peter Friend has said it already, it's not the most reliable parameter for viability. Also regarding the biliary tree, these three encircled grafts, for example, have different bile flow amount and are not predictive for any outcomes really as a single parameter. There's a target presented by Robert Porter's group of 10 milliliter bile per 2.5 hours. If we apply that to the Watson group, a couple of livers would not have been transplanted. So it's certainly not the only parameter, as we all know. The Vital paper you've seen already before, nice combination of criteria, explored higher risk DBD and DCD organs with an end ischemic normothermic perfusion after cold storage, and increase the utilization. And you see the combination of lactate and two or more other parameters, bile production, pH, all those we went through recently. You see that they fulfilled the criteria according to the definition when they started the trial, and they still developed ITBL. So this combination is not good enough for the biliary tree. And this leads to the idea of many other colleagues, including the group from Groningen and Chris Watson and all others involved, to have a more complex assessment of the bile fluid itself, because we know that the cholangiocytes contribute to the biliary composition. And basically 3 parameters are interesting in addition to sodium presented before, glucose, pH, and bicarb. And this was developed by a group from Professor Porter, and they have, based on these ex vivo established criteria, transplanted the livers. You see them on the right side, and you see a clear discrimination. There are only 6, but 4 out of 6 were successfully transplanted. And in 8 months, there was no development of an ITBL. There are several shortcomings in all viability assessments during normothermic and also hypothermic perfusion. We come to that in a few seconds. Only a few markers are specific enough, so we need a combination during normothermic perfusion. The predictors, each single predictor, are kind of weak. Each series has still lost 1 or 2 grafts. They base mainly on case series. Not all are transplanted. For example, the paper from Zurich with 7-day perfusion is great. Great work on viability assessment as well, but it's not really a confirmation that the livers need to be transplanted in the end. And we have no uniform strategy to rule out the confounders regarding perfusion. Duration, time point, and markers are very different. And if we want to assess specific cell compounds, for example, ATP, measurement would be good. It requires long time today. And I think Professor Friend made that very nice in his paper. He said we need data from much larger numbers of normothermic perfused livers transplanted, maybe from a registry or from the randomized trials, to determine more specific parameters. And this leads us to the other side of the coin. James Guarrera initially already mentioned the mechanism of hypothermic perfusion and that we can improve certain things. And if we now look at the viability assessment, we can see that the standard parameters measured under normothermic conditions do not work in the cold too. Lactate, ALT, for example, glucose, and other parameters do not correlate with graft survival and do not correlate with outcome parameters like hospital stay, creatinine, kidney function, renal replacement therapy, and the cumulative complications. So either under normothermic condition, but also in the cold, these parameters are not good enough. And the group from Turin has just shown that in a cohort with old and fatty DBD livers. But if we take the perfusate from the cold perfusion and assess it in a mass spectrometer, we get multiple parameters. So it's not true that the metabolism is completely off and we cannot measure anything. We can measure a lot. And it's just the way to find what we need to measure. And if you think back to the viability testing and what is a good criterion and a good viability test, I think we go back to the mitochondria because they fulfill, and they are the motor or the powerhouse of the cell, and they fulfill all the needed criteria. They produce energy, they protect the DNA, they are responsible for cell reproduction, synthetic processes, and also the electrochemical cellular integrity. So mitochondria are certainly the key for viability assessment everywhere. And this is not new again, it is known, you see it, reliable incidence for viability is actually ATP content. You see 3 different injuries, good livers, 15 minutes warm ischemia time, and 30 minutes. This is 30 years ago. And you see here just one example, bile flow, we know it is linked to ATP. So the importance of mitochondrial function is known very long already. And the key events, James highlighted that shortly, during ischemia, you have the accumulation of multiple parameters in the cell, in the mitochondria. The TCA cycle is on hold because the respiratory chain is dysfunctional and you lose energy, of course, and accumulate NADH in all species. Mike Murphy is an expert on mitochondria and he has published that recently again. And you know that when you move on to the reperfusion, reoxygenation, and it's under any condition the same. You reoxygenate, you have a problem in your electron flow in the respiratory chain. And the electrons, you see it with the red arrows, they cannot move through the complexes as they should, so they cannot lead to an ATP development. They go backwards and everywhere essentially, and they produce and release the initial trigger of the anti-reperfusion cascade. And this is the problem, and this is the area we need to focus on in complex 1. So complex 1 injury is the key instigator of all we measure later, all which is released into the perfusate, and all we see clinically after reperfusion. And if we look into complex 1, we see it consists of many, many proteins, and I always say there are experts who focus their entire life only on this complex. And you can really see the electrons have a backflow, and due to this reoxygenation in the first few minutes, at the electron acceptor side or docking side, there is an injury of this area or protein, and a molecule like FMN is released. And FMN needs oxygen to be measured and to be released, and it comes from the same side like the radicals. And now the question is, can we measure that? And in the green, you remember the slide from the mass spectrometry, we identified FMN in the perfusate with the mass spectrometry in more than 55 DCD livers, which were all perfused and transplanted. And you can see that here, it comes out, you can measure it. And the beauty of FMN is that it's autofluorescent. So you can just measure it with a perfusate, pipette the perfusate in a plate reader that is in most time accessible in each hospital, in each laboratory. Even the pathology laboratories have that, and you can just read it at a certain wavelength. You don't need to add anything, you don't need to pay much. It costs essentially the plate for the reader. And we have done that, and we have tested all the mechanism in the last 7 years together with experts from mitochondrial injury and function in Berlin and in the US. And you can see the FMN on the left side here, so you can discriminate between DCD livers and DBD livers very clearly in the perfusate, and you can predict the outcome after transplantation. These are 50 human livers, DCD and DBD, and you see clearly that if you cross a certain threshold in the first 30-40 minutes of hypothermic oxygenated perfusion, you lose most of the grafts with a very good correlation. And this is, I'm sure many of you have seen this correlates with lactate after transplantation in the recipient with the graft function, and has a very good AUC for graft loss after transplantation as well. And just because I would always ask what is with NADH, just to come back to that for a few seconds, NADH is also sitting at complex 1 and is known since many, many years as a viability marker in cells. And also the detection method is similar to the FMN with the fluorometry or spectroscopy is known since more than 20 years. So NADH, if the liver has a bad quality, NADH is released into the perfusate, and you can measure that. We did this in 2013 during hypothermic perfusion. You see the red curve, the NADH is metabolized because the organs are improved and you have a low value. If the injury is too high, this effect of hope is in some livers not good enough. We can treat most of the livers and improve with hypothermic perfusion, but not all. And those release NADH and also a lot of FMN, and those then do the complications. And you see in our clinical series on the right side that you can discriminate in the same way like FMN with NADH between graft loss and graft survival in the human DCD livers and at any risk. So how do we do that clinically now? Imagine you get two offers, you see them on the picture. This is the series from Philip Dudkovsky, and you see from Zurich, and you have a DCD, 50 minutes, 50 years, 51, you have 12 minutes, a short functional warm ischemia time, a little bit of fat, microsteatosis. And on the other hand, you have a 54-year-old liver, longer warm ischemia time, and a very long hepatectomy time in the donor. And we put both livers on the hypothermic system, and then we measure the FMN. You see on the left side, the second graft has a very high FMN release in 30 minutes, and also after 45 and 60 minutes compared to the other liver. And then we did the liver number 2 was declined, liver number 1 was transplanted, and you see the high perfusate NADH correlating to the FMN in the second graft. And you also see when we send the tissue, isolated tissue mitochondria to the mass spectrometry, this correlates with the remaining FMN in the mitochondria. So it is what we said, it is released into the perfusate if the injury is high and if our repair is not sufficient enough during hope. And this is very new, developed new staining from the team in Zurich. You see that you can stain this pocket in complex 1, and you can stain the injured FMN site, and you see the first liver is the one from the previous slide which was discarded, and you see that this pocket, this protein, is injured or lost compared to the transplanted and normal functioning liver with low FMN release, high FMN in the mitochondria, and good and healthy pocket of FMN in the complex 1. This is what we do clinically. We measure, and sometimes we reallocate the graft after the measurement. When we have a very high risk, high MELD recipient or retransplant, we are not so happy to go towards the threshold. So even if we are in the orange area, between 5,000 and 8,000 or 10,000 FMN, we allocate that to a low-risk recipient, HCC or lower MELD. And if we have a very good liver despite DCD, just basing on measurement and our assessment, we give it even to a high-risk recipient because of the lack of organs. The FMN, like any other parameter, needs to be validated, and part of it has been done by the group from the UK recently. You see, this is a complete different organ. It's in kidneys, and it's normothermic kidney perfusion, and they have discriminated by FMN measurement, the same technique, between graft function and no graft function in kidney transplants. And furthermore, they measured it also during NRP, with Chris Watson is involved in this project too, and could link that with transplanted and declined livers during NRP and also during NMP for the kidney. And they also confirmed that any perfusion and in the warm, like normothermic or NRP, has an injury. And this is what we measure. And this is what our viability assessment bases on in this technique. And you see the good correlation of FMN with the liver acceptance in this thing. The advantages of this spectrometry or fluorometry are clear, although they need to be validated, definitely. It's quick, real-time, it's cheap and accessible by everyone. You see the spectrometer on the right side. This is, you can find in any lab almost. FMN and NADH are consistent despite the cold storage. That is what the group from the UK has described too. And it's based on a high-risk donor liver series where it was developed and always calculated in context of liver weight and perfusate. The validation in other organs has started and is ongoing, also with the help of the team of James Guarrera and the Italian teams and the colleagues from the Netherlands and Germany. We have collected all the perfusate during cold perfusion and assess now the markers to validate it. And been validated also in other human cohorts, NRP and NMP. And very important, this parameter comes right from the core of reperfusion injury, which is complex 1, which is the site we believe we have to target to predict function in the future. And this is my last slide, future perspective. We will further explore mitochondrial markers. I'm sure these are not the last 2 markers we have. We need larger cohorts as said. We need to link it to the donor risk profile and outcomes, validate. And we need, which is important for all the parameters, we need a consensus regarding the criteria such a viability parameter has to meet to serve as a reliable predictor. And there's no consensus yet. And of course, interesting would be for all of us in the future to integrate the measurement into the new perfusion devices, which is the dream of the surgeon. You just switch the device on and then there's an ample, use it, yes, no, or pump longer. And I would like to thank all the people involved. There's a large team in Zurich with Philip Dudkowski and Matteo and Eva at the moment. Then there was a team in Birmingham, very supportive for the clinical trial, Barney, for example. And then now currently a team in Florence with Paolo Muisan and all the other colleagues, Rebecca and the physicians who are very supportive to push this further. Italy has a high-risk donor profile too. And so I would like to thank all the people involved and all the colleagues and you for your attention.
Yes, so thank you very much, Andrea, for this very educational talk on viability testing. We have 2 questions from the audience. First is from Peter Swan from New Zealand. FMN appears to be an accurate predictor. Is there any need to add NADH?
Good point, good point. For a long time, we believed NADH is better in function for complex 1 than FMN. FMN is more the injury. I think after the validation of these multi-centrally collected samples, we can answer this question more, because we will measure both and confirm with mass spectrometry, and then with these probably 200 to 300 samples, we will know more if you really need this. At the moment, we measure both.
Okay. Thank you. Then the second question is from David Reich. So he is asking, based on your viability testing, how much endoschemic hope is required? Is there a minimum duration, or do more severely marginal grafts require longer hope sessions? And there is some tension between the desire to treat longer and desire to transplant or reperfuse sooner. So
that's a very good question, David. Thank you. Initially, we always said 1 hour. When we did experimental studies in fatty livers and DCD livers, we saw that 2 hours is better. Robert Porter has also a paper mechanistically showing that the first 2 hours HCP increases more, and after 3 hours, you have not much difference. This is in line with our metabolic assessment with the NADH metabolism during HOPE. After 60, 90, 100 minutes, there's a plateau. So I think for a minimal treatment, I would say 2 hours today. That's what we said with Philip in Zurich. And the longest treatment, we have done 8 hours, we have done 10 hours, we perfuse 3 days, but this needs to be confirmed in transplantation, of course. As soon as you keep the pressure low and the conditions, the liver has enough energy to perfuse longer than 10, 12 hours, that's not a problem. So for logistics, it's certainly working, but it needs to be confirmed in the clinical setting, of course. High-risk livers, fatty livers, DCD livers benefit from longer perfusion, longer than 1 hour, certainly 2 hours, ideally probably 3 hours.
Okay, thank you. Then we have a last question from Otto van Leeuw van Groningen from the Netherlands. Do you think it will be possible one day to distinguish between FNM excreted from the hepatocyte and the cholangiocyte mitochondria?
That's a very good question. I think we are not good in isolating cholangiocytes and keep them alive to detect their function or their mitochondrial situation at the moment. So that's why we are very happy what we've seen, that we can predict graft loss by PNF and ischemic cholangiopathy with the markers now. But the other thing is that, of course, the hepatocyte with all the excretion of bile acids contributes as well to the bile composition. But this needs to be confirmed one day. If someone has a method to keep cholangiocytes alive quickly to assess the mitochondria, I'm very happy to look at that.
So yes, thank you for again. Peter and James are back now as well on the screen. We just would like to have a short discussion afterwards. I just have a question for all three of you. What do you think in the future, if machine perfusion is like clinically implemented in more centers? Should all livers be perfused or just only the high risk? Andrea, you have a smile.
We have this, I can come back to this survey we have advertised corresponding with the ILTS and ask that all our colleagues, what do you think? Which livers should be perfused? And about 20% of people in the preliminary analysis say, yes, we should perfuse all organs. Personally, I think we should perfuse all organs, and I have to say cold, I'm sorry, but I think it's easy. We have recently assessed the tumor recurrence, for example, because loads of high-risk livers are transplanted in HCC recipients. They can handle the post-reperfusion syndrome and medically more fit. So, and we've seen that even if you have a DBD liver and you do not perfuse, you get a higher recurrence rate of HCCs. So even this cohort benefits a lot from the prevention of a little bit of reperfusion injury. Experimentally, I remember what was for me the most impressive study when we did allogenic model, incompatible donor rats into recipients, and there was no injury, no DCD, no fat, no cold storage, just the transplant. Just adding 1 hour HOPE treatment in this low injury model made all animals survive. So I think we cannot lose anything. Rutger Ploch said to me once he would perfuse all the kidneys cold if he could decide. Of course, it's a long way and we need to confirm and wait for the randomized trials, but I think we cannot lose anything.
Mm-hmm. Thank you. Peter Friend, do you have
Yes, I think that we will ultimately perfuse all organs. I think if one looks at the evolution of technology generally, technology tends to come in for a niche indication, and if it's as good as it turns out as it's supposed to be, then it becomes obvious that all organs will benefit. So if, for example, we look at the logistic benefits, why should we go back to operating all night when we've got the capability of making liver transplantation into a daytime activity? Why should we subject patients to unnecessary risks just because the organ is technically lower risk? There's no such thing as a risk-free organ. I just think that at the moment, what Andrew describes, of course, is exactly what you get when you survey a population of experts, which is that there are early adopters that say yes, and everyone else says maybe or no. But the bar moves, and in 10 years' time, we will be perfusing all organs. And I'm not saying what temperature, but of course it'll be warm.
Okay. Well, then we have our third speaker, James Guarrera. What do you think, or do you see something like an organ hub, or?
Well, I'm going to have to play counterpoint on this. My block time in my hospital begins at 10 p.m. and goes till 6 a.m. So, yeah, I really hope that we'll be able to fix the logistics, but you'll create a whole new different problem with logistics, and that if the transplant surgeons are doing all their cases during the day, the orthopedic surgeons and neurosurgeons that are doing other stuff are gonna push back at some level. So I think institutionally the idea of that we can operate during the day, hopefully we have enough gravitas to make that happen. That being said, I think we'll be perfusing the majority of cases, because I think most cases, at least the cases that that I'm doing, are either the recipient is very sick and metabolically challenged, and as Andrea said, is going to be, has risks associated with reperfusion and instability and subsequent renal failure and complications, coagulopathy and such. So I think for that reason, there's definitely a host recipient based indication. There's a lot more graft rate. We talked about that at length. And then there's a logistic. But I think, if I get offered a liver and the donor goes to the OR at 4 a.m. and it's a 20-year-old and, gunshot wound to the head, and I'm doing a tumor patient with a MELD of 6, I'm going to just put that liver in. I'm not going to put it on the pump. I'm going to put it in, because my 1 year survival for that patient is 99.5%. But I think, it depends on your program and sort of what your comfort level is. But I think there will be cases that you'll just put in just for simplicity and logistics. But that being said, I believe that if you look at all comers in most people's practices, either the graft will have indications that we use perfusion, the logistics, or the recipient. And I think that's going to be the vast majority of cases. There will be outliers that you may just opt just because it's all teed up and the OR is ready and you can just put it in with 5 or 6 hours of full time. And those cases I probably will continue to do if the logistics are favorable. But that's just me.
Yes, so thank you all for your comments. I just have another question. We have some reports as well about combining hypothermic and normothermic machine perfusion, or the NRP, so in the donor, and then an end ischemic perfusion as well. Does anyone have a thought on that?
Sorry, could you repeat that question? I didn't quite catch it.
It's about combination of treatment. So some groups have described for like very high risk DCD with a long functional warm ischemia time, or high age or high BMI, that they did like a combination, first hypothermic machine perfusion and then normothermic, or NRP and then normothermic or hypothermic. What are your thoughts on that?
Shall I start? I think there's a very interesting area of science which is about rates of change and going from cold to warm, for example, should be done more gradually. So it is quite conceivable that we will not end up with a binary choice in the future. We won't have machines which are cold or machines which are warm. We may have machines which do graduations. We're beginning to see some quite good experimental evidence that what you don't want to do with an organ is to change its temperature very rapidly. So I suspect that's a sort of, I suspect we are dealing in an era of a kind of artificial divide at the moment.
Mm-hmm. Yeah, that's a very good point. I think it depends at the moment very much on what is the practice in the country. These combinations of NRP plus cold perfusion, for example, in Italy, is compulsory for DCD donors. So they do that always. To fully answer that question, we need more data. The controlled rewarming is interesting. As soon as we are more safe with the viability assessment, either in the cold and in the warm, we maybe don't need that combination anymore. And the other thing is what Peter already mentioned, this change of temperature. Organs do not like, we are not hibernators, we're not used to that. So organs don't like that. And if I rewarm, then I have to flush in the end again at room temperature or cold to get the perfusate out. But we go down again with the temperature. And we need more data if this is really good, in which livers, and how we combine that.
Mm-hmm. Okay, thank you. I think we have, because we are already like almost half an hour over time. Does any three of you have anything to add at the end, or? I think we have had a very nice session today. It was very educational about hypothermic machine perfusion, also normothermic machine perfusion, and the viability testing. Next week, we also have a very nice webinar that is waiting for us about liver machine perfusion at the front line, with talks from Cristiano Quintini, Paolo Moisan, and Paolo Martins. So we all hope to see you again next week. It's also on Friday the 6th of November at 3 p.m. European time. And at last, I would like to thank again, also from ILTS, to Bridge to Life, that they supported us to making this webinar possible. Thank you very much, also the speakers, for today.
Thank you very much. Good seeing everybody.
Have a good weekend.